is Dr. Gupta. I'm a certified orthopedic surgeon in Woodbridge, Virginia, and I'm a private practitioner in orthopedic and spine care. And 2 years ago, I started a center called Ortho Laser Woodbridge. And at Ortho Laser Woodbridge, we have a task for dual-wave laser, which we've been using to treat acute chronic and post-op pain in our practice. And this presentation today is going to discuss the basic science of laser therapy as well as how I use it in my practice. And we'll give you a little historical perspective as well. So, pain has now officially been sort of treated as a fifth vital sign in our practice. Right? We ask everyone their pain scale. You see the posters up on walls all the time to these rate of pain. And unfortunately, companies like Purdue Pharma got in early on the pain crisis and converted that to an opioid crisis. And surgery became an important gateway for opioid addiction, unfortunately. So when you talk about laser therapy, you talk about a big fancy term called photobiomodulation. Photo means light, bio means living cells, and modulation means exerting influence upon. So it describes the biomechanical reactions that occur in living cells in response to light. We see this in other places as well, such as photosynthesis. And our own bodies use vitamin D and sunlight activation to improve the quality of our bones. Unfortunately, photobiomodulation hasn't been taught very well in our medical school curriculum, and therefore hasn't really gained a lot of mainstream acceptance by clinicians. There is one school in Florence, Italy that does teach this, and laser therapy was first introduced in Europe about 40 years ago. We came to market in the early 2000s. And so it would make sense that the Europeans are a little bit more ahead of us as far as using laser therapy as a treatment modality. So, like I mentioned, it first came in the animal model here in the early 2000s, traditionally with vets. So we've all heard of our neighbor's dog or friend's dog getting treated after ACL surgery. In the equine model, especially equestrians and animals are getting treated as well. And more recently, and we'll discuss this going forward, our academy, the American Academy of Orthopedics and the CDC both approved laser therapy for the treatment of acute chronic and subacute pain. So what is the mechanism of photobiomodulation? Well, laser form of light is energy. A unit of light is a photon, and photons interact with our cells. And so this energy is transferred to our cells, and those cells create a biological reaction, which then creates a healing response. So what is a cellular response to laser therapy? Well, light goes into the mitochondria and activates an enzyme called cytochrome oxidase, which then increases ATP production, which is the energy source that our body uses. And then this creates a downstream chemical messenger, which then leads to the production of RNA, and then ultimately cytokine production, which is a type of protein that effectuates the cellular response, leads to an inflammatory reaction and localized recovery. So what are the downstream effects? The anti-inflammatory effects of laser therapy. Well, number one is the reduction of an anti-inflammatory cytokine called IL-10. There's a reduction of pro-inflammatory cytokines called IL-6. And it also creates angiogenesis, which is the formation of new blood vessels into that localized tissue area. Neurogenesis, so you production of new nerve cells in the area. High local productions of increase in muscle tissue, and fibroblastic ingrowth, which is new blood vessels and capillaries into the tissue, which leads to a reduction of macrophages, which are inflammatory cells, and eventually a recovery response. So, like for solar flares, um, let's talk about the light that we get from the energy we get from visible light. So, visible light is spectrum of roughly 400 to 6 to 750 nanometers. That's all the way from violet to red light. And when we talk about laser therapy, we should distinguish the difference between LED light and laser light. So LED light, LED stands for light emitting diode. All red light wavelengths are in the range of 620 to 750 nanometers. The most important part about LED light is the depth of penetration is only 3 to 5 millimeters. So just under the dermis, under the skin. So they consider low power, less photons, so less energy transfer. And because of that, we need a higher maximum area to be able to absorb that energy. So you need more skin to be um, exposed. And it's not ideal for localized musculoskeletal conditions because it's not getting into the details. It's just getting more generalized just under the skin. So again, it's best for systemic conditions. Laser therapy, so laser stands for light amplification by stimulation with emitted radiation. It's typically a single or dual wavelength. It's high power, so that means more photons, more energy transfer, more cellular response, but it's localized versus systemic biologic activity ideal for MSK conditions. So the laser that we use penetrates the skin deep enough into the bones and joints, typically 5 to 8 millimeters. So does red light LED therapy. A lot of our patients come and say, hey, I bought this LED light off Amazon, I use it at home. Isn't it the same thing? Well, not really. If you were to lay in an LED bed, you could have some systemic anti-inflammatory effects. You'll see some cutaneous vasculature. It will stimulate some red blood cells and white blood cells, but it's more systemic illness versus, again, localized musculoskeletal conditions, and often used by athletes for recovery. And again, you need a large surface area. So that's why musculoskeletal conditions are ideal for laser therapy and weight. So typically, laser therapy will be anywhere from 808 to about 940 nanometers. And again, that will penetrate the skin significantly deeper, especially with obese patients, you're getting to the deep throat. So this is the laser that we use. It's a near infrared laser that emits at 808 and 909 nanometers. It's a robotic arm, but there's also a wand that you can use for dynamic treatment. So, for example, let's say you have a patient that has chronic plantar fasciitis with first tendonitis. You can place the hanging arm on the Achilles tendon, for example, and then you can dynamically stretch the foot and then one the plantar fascia, or vice versa, right? So it's kind of nice that way compared to other treatment modalities where you're getting that dynamic treatment as well, thereby loosening up the tension and getting more pliability. So, in full fairness, before we opened this 2 years ago, I did feel a little bit like a snake oil salesman, talking about laser therapy. But 2 years in now, I've become very comfortable talking about it as I've seen my patients have responded to it. And that is just another tool, my toolbox for non-opioid treatment for pain and various musculoskeletal conditions. So, laser modulates cellular activity. Again, we're not treating diseases. We're treating the localized cellular environment, and then by improving the cellular environment by decreasing the inflammatory mediators and increasing the anti-inflammatory mediators, thereby reducing local inflammation, improving the condition, and improving the patient. So, my practice, I use it for acute musculoskeletal injuries for multiple sclerosis patients. And this is just a small sample of all the chronic conditions that we treat as well. Doesn't work. So, like I mentioned, it's been used in Europe for about 40 years, so there's thousands of studies looking at the effects of laser therapy and the biomechanical and the basic science behind laser therapy. And like I mentioned earlier, our Academy of Orthopedics approved it for knee arthritis. The CDC approved it for acute, subacute, chronic pain. And when you look at our Ortho Laser Center, 96% of patients are pleased with the quality of care. 89% would return for treatment on another body part. 83% of patients are happy with the results, and 97% felt comfortable and at ease during the treatment. Now, the laser that we use operates at two wavelengths, and it rapidly alternates between those two wavelengths, and that's important because it doesn't generate heat. The patients are extremely at a zero risk for being burned. So we tell the patients you won't see it, you won't feel it. In fact, you probably won't notice the difference in pain until after about the fifth or sixth session because this is a dose dependent attack. Meaning, if you miss a few sessions, you may not see full improvements. And when a prescriber puts out a certain number of units, it's secondary to the fact that it is dose dependent. Okay, so how do I use it in my practice? So for acute pain, I use it for sprains and strains, usually injuries less than 2 to 3 weeks, combining it with a rest protocol and physical therapy. Agent for all nine post-op patients, I found that really helped decrease the post-op pain and swelling and improve the range of motion again in combination with physical therapy. And for chronic patients, these are all more challenging, obviously. So they usually require longer treatment protocols, secondary to the underlying levels of the chronicity of their pain. I treat all my short size patients, usually with personal injection, physical therapy, and laser therapy. For hip and knee patients that aren't candidate for surgery, when they delay surgery, chronic low back and neck pain with and without related left pain with the one, we can trace the nerve, thereby sort of decreasing or lowering the pain there that is associated with the radiculopathy. And what we're finding with our chronic patients, especially with our lower back and neck, because these are long-standing issues, oftentimes will require more sessions to really alleviate their pain. Last year, we treated 1,200 patients at Ortho Laser Woodbridge, and you'll hear a few pearls. Acute chronic conditions usually require 2 to 3 times a week, as prescribed by the referring physician. Each session takes anywhere from 5 to 15 minutes. Like I mentioned before, it is a dose-dependent effect. Patients may feel fatigue after therapy. They are receiving a lot of energy imparted into their body, and so that may result questions on how their patients being a little bit more tired. It is very synergistic with physical therapy and cortisone injections. And for acute injuries, we recommend starting immediately to minimize swelling and pain. For our work comp patients, it's opioid sparing. It has been shown to decrease pain and swelling with improved mobility, so faster recovery times. We send all our notes to adjusters, and more importantly, the centers in constant communication with physicians regarding the progress of the patients. We developed a flagging system so patients are not progressing well, but there's a specific clinical issue that